Welcome back to the deep dive. Today, we are plunging into a body of knowledge that is probably one of the most crucial in all of medicine, antenatal and obstetric care.
Or ANC. Yeah.
Right, ANC. And if you've ever looked at the clinical summaries for pregnancy and just felt completely overwhelmed by the sheer volume of screenings and timelines.
And all the acronyms.
Oh, the acronyms. You are definitely not alone. So our mission today is pretty straightforward. We've taken a huge stack of clinical source material, the real protocols, and we're going to distill it for you.
We want to get to the non-negotiables.
Exactly. The most crucial checks, the specific risk factors, and maybe some of the more surprising details you need to know. We really just want to equip you with a fast-track understanding of modern pregnancy care.
And the first thing that really jumps out when you look at the structure of it all is how deliberate the planning is. I mean, this is not a one-size-fits-all journey.
It's highly differentiated.
It is. The sources are very clear. For a woman pregnant for the first time, a nulliparous woman, the protocol recommends 10 appointments.
10.
But if you've given birth before, so you're multiparous, that number drops to 7. And it all kicks off with that essential booking appointment, usually right around the 10-week mark.
That's fascinating. It signals that a prior successful delivery actually reduces the monitoring load. So, okay, let's unpack that first step, that initial booking appointment. The investigations seem to cast a really wide net.
They do.
We're talking infectious disease, hematology. What are the absolute must-dos in that first infectious disease screen?
Well, that initial screen is all about preventing transmission. So you're looking for hepatitis B, HIV, and syphilis.
The big three.
The big three.
Okay.
Finding them early allows for interventions that protect both the mother and, of course, the fetus. And at the same time, you've got the whole hematology deep dive happening.
Which involves what exactly?
A full blood count, establishing the blood group, and, this is critical, the rhesus D status.
Okay, tell us why rhesus D is such a pivotal piece of information.
Because it can define the entire management pathway for the rest of the pregnancy. If a mother is rhesus negative, she's at risk of creating something called low antibodies.
And those are all bad.
They are. They're antibodies that can cross the placenta and attack the fetus's blood cells. It can lead to, severe anemia or jaundice in the baby. Finding this out early is how we plan the preventative treatments, like anti-D immunoglobulin.
So it's all about getting ahead of the problem.
Getting way ahead of it. And that initial screen also looks for things like sickle cell disease or thalassemia.
Right. And what's interesting is even after all those detailed labs, the monitoring it's constant. There are 3 things you track at every single visit, right?
Yes, that's the continuous safety net. Every single appointment, you're checking 3 things. A urine dipstick.
For infection or preeclampsia signs.
Exactly.
Yeah.
Then meticulous blood pressure monitoring and tracking BMI. These are just rapid checks for any systemic changes happening between visits.
Okay, so let's move to the visual side of things. The ultrasounds. The sources make a really clear distinction between the dating scan and the anomaly scan.
They're very different tools with different goals.
Yeah.
The dating scan happens in the first trimester, somewhere between, say, 11 and 14 weeks.
And its purpose is just logistics.
Pretty much, it's to accurately establish the gestational age, to set the due date, and to confirm if it's a multiple pregnancy.
And the anomaly scan.
That's the big structural checkup. It happens later, around 18 to 21 weeks. It's a really detailed inspection, looking for any structural abnormalities and confirming where the placenta is located.
And that timing is key because it opens the window for other screenings, like for trisomy 21 Down syndrome. That's offered to everyone, but the test you get depends on when you present.
Exactly right. If you're in that optimal window between 10 and 14 weeks, you're offered the combined test. That blends a blood test with the neutral translucency measurement from the ultrasound.
And if you're later than that?
If you're seen later, say between 14 and 20 weeks, then it's the quadruple test, which is just a different set of markers from a blood sample.
Now, this is where it gets complicated. If that initial screen comes back positive, what happens next? There's a big trade-off the patient has to weigh, right?
A huge one. The definitive diagnostic tests are either amniocentesis or chorionic villus sampling CVS. They give you a certain result, but they carry a risk. The sources consistently cite a 1 in 100 risk of a procedure-related miscarriage. And that figure, that's a major part of the counseling process.
That's a heavy decision. Okay, let's transition to managing risks that can pop up later, starting with gestational diabetes or GD. The sources say it's usually asymptomatic, but it has long-term consequences.
It does. A significantly increased risk of developing type 2 diabetes later in life. But the immediate risks for the baby are really profound. Well, GD can drive fetal overgrowth, what we call macrosomia, a large baby, which, complicates delivery. It also ups the risk of preeclampsia, prematurity, and all sorts of issues for the newborn, like respiratory distress and um, dangerously low blood sugar.
It sounds like a really high-stakes condition. So who gets put in that high alert category for screening? I think our sources list 5 main risk factors.
They do. The big ones are a history of GD in a previous pregnancy, a BMI over 30, a direct family history of diabetes, having had a previous baby over 4.5 kilos.
That's a big baby.
It is. And finally, being from certain ethnic minority backgrounds where diabetes is more prevalent.
And the testing happens when?
Usually between 24 and 28 weeks. The diagnosis is very specific. A fasting glucose over 5.6 or a 2-hour reading on the big glucose strength test, the OGTT above 7.8.
So once you have that diagnosis, what's the management plan look like?
It's staged. It always starts with lifestyle and diet changes. If that doesn't work, the first-line drug is metformin, then insulin.
And there are specific triggers for insulin.
Very specific. Insulin is required if the fasting glucose is persistently over 7, or if it's in a high range, say 6.1 to 6.9, and there's another risk factor present. And here's a great detail for you. Glibenclamide is the only sulfonylurea drug allowed in pregnancy.
That kind of specific detail is exactly what we're looking for. Okay, let's pivot to hypertension, another huge risk. It seems to exist on a spectrum.
It does. You have gestational hypertension, which is just new high blood pressure over 1490 that shows up after 20 weeks.
And then there's the much scarier one.
Preeclampsia, which is that new hypertension plus protein in the urine. And it's not just about hitting 1490. They're also watching for a sudden jump from the patient's baseline pressure.
And preeclampsia can be devastating. What are the big red flag symptoms?
The classics are a persistent headache that won't go away, visual disturbances, and in the most critical cases, you get what's called HELLP syndrome.
HLLP.
It's an acronym. Hemolysis, elevated liver enzymes, and low platelets. It's a sign of total systemic breakdown. And the most sobering fact about preeclampsia is that the only cure is delivery.
The only cure is to end the pregnancy.
That's it. The condition can't resolve otherwise.
Which is why prevention is so critical for high-risk patients. What's the protocol for using aspirin?
It's a very clear checklist. Aspirin is offered from 12 weeks all the way to birth if you meet certain criteria. You need either one major risk factor like pre-existing hypertension or diabetes, or you need 2 of the minor ones.
And the minor ones are things like a first pregnancy, BMI over 35.
Exactly. First pregnancy, multiple pregnancy, BMI over 35, being over 40. It's a structured way to identify who needs that prevention most.
Okay, let's move on to a very sensitive topic, but one that requires real clinical precision, bleeding in early pregnancy. Our sources break down miscarriage into 5 distinct types. Why is that terminology so important?
Because the definitions really drive the action. They dictate what to expect and what to do. For instance, a threatened miscarriage. You have some bleeding, but the cervix is closed and there's a heartbeat.
So management is just observation.
Reassurance and observation, yes. Compare that to an inevitable miscarriage. There's significant pain, heavy bleeding, and the cervix is already open. The loss can't be stopped.
And then there's complete, where it's already over.
Right. No retained tissue, cervix is closed again. Then you have the other two. A missed miscarriage, which is often silent. No pain, cervix closed, but the ultrasound shows no heartbeat.
And the really dangerous one?
The septic miscarriage. That's a life-threatening infection. Fever, severe illness. It's an emergency.
And the management options for these? They vary.
They do. You can have expectant management, just waiting. Medical management with a drug like misoprostol. Or surgical management, like a vacuum aspiration, especially if there's a risk of infection.
And we have to remember, early bleeding isn't always a miscarriage. We should touch on ectopic and molar pregnancies. What are the key risk factors for an ectopic?
The risks for ectopic pregnancy all center on things that might damage the fallopian tubes. So history of IVF, pelvic inflammatory disease, any tubal surgery, smoking, being over 35.
And the presentation is classic, right? The shoulder tip pain?
Yes, abdominal pain, bleeding, dizziness, and that classic referred shoulder tip pain from blood irritating the diaphragm is a huge red flag. Treatment is either emergency surgery or medical with methotrexate.
Let's go back to prevention for a minute. Folic acid. It's so crucial for preventing neural tube defects. What's the standard dose for most people?
The standard recommendation is 400 micrograms daily. And you should start that before you even conceive and continue it up to the 12th week.
But, and this is a vital point for anyone listening, there's a whole group of people who need a much higher dose, the 5 milligram protocol. Who falls into that category?
This is a critical checklist. Anyone with a personal or family history of a neural tube defect. Anyone with pre-existing diabetes, type 1 or 2, patients on certain anti-epileptic drugs, people with coeliac disease or a BMI of 30 or higher.
That's a big list.
It is. And there's one more specific group, patients with sickle cell or thalassemia. For them, that 5 milligram dose needs to be taken throughout the entire pregnancy, not just the first 12 weeks. That is a must-know distinction.
Absolutely. Okay, let's cover rhesus management. We mentioned how important that rhesus D status is. What's the actual schedule for anti-ED?
For any patient who is rhesus negative, they get prophylactic anti-D shots at 28 weeks and again at 32 weeks. It's just a preventative measure.
But the sources stress that it's required for a huge list of other events, too.
Oh, yes. It's used proactively in basically any situation where there's a risk of maternal and fetal blood mixing. So that includes any miscarriage, surgical management of an ectopic, amniocentesis, any kind of abdominal trauma, any bleeding.
It's a very aggressive protocol.
Extremely. Because the consequences of sensitization for future pregnancies are just so severe.
All right, shifting gears into the later stages of pregnancy now. There are a couple of common itching conditions, but they're very different. Let's contrast intrahepatic cholestasis with PEP.
Right, this is clinically essential. One is just an annoyance, the other is very serious. Polymorphic eruption of pregnancy, or PEP, is basically a common skin rash.
Third trimester stuff.
Exactly. Plaques and papules, usually on the lower abdomen. It's uncomfortable, but it's not dangerous. You treat it with emollients and maybe some topical steroids.
And the other one?
Intrahepatic cholestasis of pregnancy is a liver disorder. The itching is intense, it's often on the palms and soles, and it's always worse at night. Critically, blood tests show high bile acids.
And that one is dangerous.
Yes, it's linked to an increased risk of stillbirth, so it has to be managed aggressively with medication, and it usually means inducing delivery by 37 weeks.
That's a huge difference. Okay, let's briefly touch on anemia. The diagnostic criteria actually change by trimester, right?
They do, because of the natural changes in blood volume. The threshold for anemia is a hemoglobin below 11 in the first trimester, but it drops to below 10.5 in the second and third. Postpartum, it's below 10.
Simple iron supplementation is the usual fix.
Usually, yes. A 3-month course of iron.
And beyond cholestasis, what are the other serious causes of jaundice in pregnancy?
The big three are HEL-LP syndrome, which we've mentioned, acute fatty liver of pregnancy, which is very rare, but life-threatening liver failure, and then intrahepatic cholestasis again. Recognizing the triad for acute fatty liver jaundice, pain, and low blood sugar is a major clinical alert.
Let's close out with drug safety. For anyone listening, what are the absolute do-not-use medications that show up again and again in these protocols?
It's a pretty long no-fly list. Tetracycline, methotrexate, the antithyroid drug, carbimazole, lithium, all benzodiazepines, certain sulfonylureas. You also have to be very careful with anti-epileptics.
Some are safer than others.
Right. Lamotrigine and levetiracetam are considered safer options, but there's a huge warning against sodium valproate and also phenytoin, which has a known link to cleft palate.
And for thyroid disorders, you mentioned the drug actually changes.
It does. You use PTU in the first trimester, then switch to carbimazole for the second and third. And interestingly, neither of them is considered safe for breastfeeding.
That just highlights how complex prescribing can be.
Finally, let's wrap with mental health. The sources separate this into 3 postpartum conditions.
Yes, based on severity and timeline. You have the baby blues, which is incredibly common, affects maybe 60–70% of new mothers. It's in the first week and just needs reassurance.
Then what?
Then you have postpartum depression, about 10%, shows up a few weeks later and is managed with therapy or antidepressants like sertraline. And then the most severe but rarest form is postpartum psychosis.
And that's an emergency.
A true medical emergency. It affects only about 0.2%, but it requires immediate hospital admission for both mother and baby. And the 2 screening questions they use everywhere are simple. Have you been feeling low? And have you not been finding pleasure in things?
Simple but powerful. Absolutely. And one final systemic issue to mention, obesity. A BMI over 30. It's not just the risks we know, like diabetes. The management protocol itself changes. You're immediately on the high-dose 5 milligrams of folic acid. And if the BMI is over 35 or 40, it mandates a full multidisciplinary team GP, obstetrician, anesthetist because of the increased risks during delivery.
Wow, that was a deep and, frankly, eye-opening tour of modern antenatal care. From the specific insulin triggers to the 5 milligram folic acid dose to the subtle differences between a missed and a threatened miscarriage. The entire field is just built on constant risk assessment.
It really is. And I want to leave you with one final, very specific clinical detail that's a huge decision point late in pregnancy. It's about managing a breech presentation.
When the baby's not head down.
Exactly. When you're considering an external cephalic version, or ECV, the procedure to manually turn the baby, the sources lay out some really strict contraindications.
What are they?
ECV is an absolute no-go if the patient has had 2 prior C-sections, if the membranes have ruptured, if there are uterine scars, or if they've had any bleeding in the last 7 days. These are hard stops. Maternal safety comes first.
That's a critical detail, and it makes you think, despite all these advanced screenings and preventative measures we've covered, the aspirin regimens, the high-dose folic acid, we're still faced with these ultimate physiological limitations. What does it tell us about pregnancy? That the only cure for preeclampsia is delivery? Or that we still rely on a drug like methotrexate for ectopic pregnancy? It really speaks to the fundamental, delicate, and sometimes just precarious balance of the whole process, doesn't it? Something for you to definitely mull over.